Hello, I'm Dr. Ira Nash. Welcome to Well Said. Do you find yourself rushing to the bathroom more often or feeling like you still have to go even after you've just been? Getting up at night to urinate? You could have lower urinary tract symptoms, or LUTS, a syndrome that is very common, especially as we age. Today we're going to explore who are more likely to develop these symptoms, why, and what can be done about it. To help us, we're joined by today's guest, Dr. Adam Cole. Dr. Cole is a board-certified urologist and an assistant professor of urology at the Zucker School of Medicine. He's also the Associate Residency Program Director for Urology at the Zucker School of Medicine at North Shore LJ. Adam, welcome to Well Said.
Thanks so much, Ira. Very happy to be here.
All right, so before we start getting into symptoms, I'd like to start with a lesson or maybe a reminder about basic anatomy. So I referenced the lower urinary tract in my intro. What constitutes the lower urinary tract?
Great. Yes, great place to start. And this is often how I start when I'm explaining to patients. I draw pictures. So it's a little different in men and women. So it starts with the bladder. The bladder main function is to store urine in a low pressure setting. And then when your brain senses that your bladder is full, to help empty the urine. In men, there's also a prostate, which is an organ that sits under the bladder. It's about a walnut size, and it can grow and wraps around the urethra, the tube that connects the bladder externally that you urinate out of, the P tube. And as you get older, it can grow and squeeze on the urethra and cause some of these urinary symptoms. In women, there's no prostate. The bladder empties straight into the urethra, which is a lot shorter, and that's how women empty. And in both men and women, there's also a pelvic floor, which weaken as you get older or become a little too tight due to various conditions, can cause other urinary symptoms.
Okay, so we'll get into that. But just in general, when we're talking about the lower urinary tract, it's lower relative to the kidneys?
Correct.
Right? So it's just the bladder and urethra?
Correct. Just bladder, prostate, urethra in men, and bladder and urethra in women.
Okay. What are the official lower urinary tract symptoms that I was kind of alluding to earlier?
There are symptoms that are related to how you urinate, and we kind of break them up into storage symptoms and voiding symptoms. So storage symptoms are also thought of as more irritative symptoms. So things like increased urinary frequency, going to the bathroom too much, urgency, the sensation of, all of a sudden feeling like you need to use the bathroom, nighttime urinating, which we call nocturia, and then incontinence or leakage of urine, which is unintended. Then there's also voiding symptoms, which are symptoms more in the line of, weak urinary stream, having a difficult time initiating stream, having to push your urinary stream, or, starting and stopping of your urinary flow. These are thought to be more obstructive in nature, maybe a little bit more mechanical. Think of it as like, kinking of a hose.
How common are those symptoms? And I guess I should ask, do they often come in a constellation, or are we talking about isolated symptoms?
First, they're very common. This is one of the most common things that I see in my office. It's estimated that about 40-50% of people worldwide experience some form of lower urinary tract symptoms. And to your question, you can have a purely irritative symptoms, purely obstructive symptoms, or some combination. So you can have both. It does increase as you get older. So it's thought that, men in their 50s, about 50% of them have these symptoms. And as they get into their 70s, almost 70 to 80% of men can have these symptoms.
We've been talking about symptoms, and I want you to help me clarify something, whether this umbrella term is really just about symptoms or something else. It strikes me as a little unusual to have a medical condition named just for the symptoms as opposed to the cause. And I was thinking about this in anticipation of our conversation, and it's a little bit like saying, to me anyway, coughing, sneezing syndrome instead of saying viral upper respiratory infection. Could you clarify whether there's really some sort of unifying condition that we should be talking about, or does it really make sense to just keep talking about these symptoms?
And I think that's a great analogy because, patients don't come into my office and say, I have BPH or I have an overactive bladder. Some
BPH is
benign prostatic hyperplasia, so an increase in the size or number of prostate cells.
Okay.
They come to my office saying, I pee too much or I'm waking up too much at night. So lower urinary tract symptoms, or LUTS, is a constellation of symptoms, some combination of those irritative and obstructive symptoms that we talked about. What's my job as a urologist is to try and figure out what is the cause of those symptoms. So there are many causes. It could be BPH, which I referenced, which is an enlarged prostate, which is something that's one of the more common causes in men, but there's a lot of other causes. It can be overactive bladder. It can be urinary tract infection. It can be sometimes a sign of bladder or prostate cancer. There could be neurologic reasons. It could be related to the fluids that you're drinking. So it is kind of a catch-all term for these symptoms, and that's, kind of the first diagnosis diagnosis that we make, and then through further history, physical testing, we can potentially make more refined diagnosis.
Okay, so let's dive into that a little bit more deeply to sort this out. So let's start with expanding on what you said before. Let's talk about who's at risk for developing these. So you said it becomes more common as people age. Are there other particular risk factors that cause people to be more likely to suffer from these things?
Yeah, there are. So genetics is one risk factor. So there are studies that show that, for men whose father has a history of an enlarged prostate, they're more likely to have an enlarged prostate. Now, again, these things are common, but for men who have a, significant family history, maybe a father who had to have surgery or something, they're potentially more at risk. There are lifestyle factors that can play a role. So smoking is a big one. So smoking is an irritant to the bladder, so it can irritate the lining of the bladder, make you feel like you have to pee more frequently. It can also increase your risk of cancer, so bladder cancer, prostate cancer. Those cancers are more prevalent in people who smoke. And there's also a hypothesis that it can lead to, inflammation, and that inflammation can sometimes lead to signaling pathways that can, increase the size of a prostate.
Obviously, the prostate-related things are limited to men, but are there other differences in risk factors between men and women, different patterns of who gets these sorts of symptoms?
Men and women get different symptoms in general. So, in men, the most common diagnosis is an enlarged prostate. Those are more obstructive type symptoms. So those are things like having a weak urinary stream, having a more difficult time urinating. Women have a shorter urethra, so it's less likely to have these obstructive symptoms. They can still have them for different diagnoses. Some women can have a very tight pelvic floor, which can make it difficult to avoid. They have differences, right? So some women in their life get pregnant, and that can lead to other urinary symptoms. Sometimes that can cause a weak pelvic floor, which can make women more likely to have incontinence or leakage. There's also some hormonal differences. Testosterone is a hormone in men. In the prostate, testosterone gets converted into something called DHT, dihydrotestosterone, and that can actually make the prostate grow as men get older. And then estrogen, we also know that women that go through menopause are more likely to have some of these urinary symptoms, some of these overactivity symptoms, and also are more prone to get urinary tract infections.
So obviously, the more fluid you take in, the more you need to urinate. Other than that obvious connection, how does diet play into this, if at all?
That's one of the questions I ask patients when they come in, is I'm going over their history, but I ask specifically about, how much fluids you're drinking and what type of fluids you're drinking, and then also diet. So, with regards to fluids, obviously one thing, drinking a lot of water is very good for you. It's good for your kidneys, but something that we often look at is we ask patients to record how much they're drinking, because sometimes we find patients are saying, yes, I pee every couple hours, but when you look, they're really drinking, 100 ounces or something, maybe more than we would recommend, and that's the reason they're peeing so much. Irritating fluids, so things like caffeine, things like soda, artificial sweeteners.
So let me ask you about that, because this sort of, urban myth that diet soda makes you need to urinate more frequently, is that really a thing?
That's really a thing. So there's two parts to it. One is the artificial sweeteners are irritating to the bladder, so they actually can affect the lining of the bladder and make you feel like you have to pee more frequently. They also often have caffeine in them, which is also an irritant. And then there's also some newer data that carbonated beverages can have the same effect, that they can make you
Yeah, so explain that. Many of us have had that experience where you drink, even a club soda, and it feels like it has more of an impact on the need to urinate than if you had the same volume of still water. Why is that?
The short answer is we don't really know. It's thought that maybe the CO2 can be somewhat irritating to the lining of the bladder. Normally what happens in a bladder is you hold about a Coke can's amount of urine in your bladder, about 500 milliliters in your bladder. But if you drink something that's particularly irritating, like caffeine or artificial sweeteners or carbonated beverages, it can sometimes increase the sensitivity of your bladder and make you feel like you need to urinate before your bladder is actually full.
Okay, so that's really a thing.
It's really a thing.
Okay, good to know.
And the other thing I'll say about that is, I see a lot of patients that come in and are telling me these symptoms, and, there's a whole workup that we do to make sure there's nothing bad going on. But I often tell patients that, even me personally, I have about 2 cups of coffee in the morning, and I know that in the first few hours of the morning, I'm going to be urinating more frequently. And that's just a product of the caffeine. And it's a risk benefit. I like having my coffee in the morning. I know it's going to make me urinate more frequently, and I'm okay with that. But if it's something that's particularly bothersome, then maybe you should cut down the amount of coffee or caffeine you're drinking.
So let me ask you a couple of follow-ups to that. So you mentioned that a lot of people feel compelled to drink a lot of water for some presumed health benefit. How much water do you suggest that your patients drink?
Yeah, so the American Kidney Foundation recommends about 64 ounces of water per day. And that's usually what I counsel patients as well.
That's a lot of water.
It is a lot of water, yeah. And obviously, if you have other health conditions, if you have kidney problems and maybe your doctor, your nephrologist recommends more, that's what you should go with. Or if you have, some people have heart problems and are fluid restricted, they shouldn't drink that much. 64 ounces is about what we recommend. That includes sodas, teas, coffees, because I think sometimes patients will say, we recommend 64 ounces of water, and they're drinking that, but also drinking
2 cups of coffee.
2 cups of coffee,
right,
having
okay.
a soup, having a juice, and those things all add up.
Okay.
It's very hard to study the effect of diet on different conditions, right? You have
Sure.
to, randomize people and control everything that goes into their mouth. There have been some retrospective studies looking at this, and they found a couple things. One, that higher fat content actually increases your risk of developing these urinary symptoms and BPH. Red meat has also been associated with some of these symptoms, specifically in a large prostate. Eating red meat, they compared having it 4 times a week compared to 1 time a week increased your risk of having these symptoms.
And is the mechanism of that understood?
Not really, no. Again, a lot of this is kind of retrospective data. We don't really know the mechanism, but this has been seen also in prostate cancer, right? There was an interesting study that came out of Japan where, before they had a very low incidence of prostate cancer. And then after introduction of a Western diet, the incidence of prostate cancer went up. So is it something about the fat leading to more inflammation that's causing this? We don't really know. We typically counsel men and women to, adopt kind of like a Mediterranean diet. So something that, high in fruits and vegetables, limiting red meat. Some other foods that can be good are actually something called lycopene. So lycopene is something that's naturally found. It's found in red fruits and vegetables like tomatoes. And it's been shown to decrease the risk of developing BPH and also decrease the risk of developing prostate cancer. Watermelon and tomatoes are kind of the fruits that have the highest amount of lycopene. It's more in cooked tomatoes, but that's something that men can eat that may help prevent these symptoms.
And for women, you said obviously the prostate issues don't apply, but are there other dietary things that apply to women that affect the likelihood of developing these sorts of symptoms?
Going back to that Mediterranean diet, so obesity and what's called metabolic syndrome, so obesity, high blood pressure, high cholesterol level, that increases your risk of having these urinary symptoms. The mechanism is somewhat unclear. Is it that there's more intra-abdominal pressure? So it's putting pressure on the bladder, making you urinate more frequently. Again, is it fat causing inflammation? But BMI is correlated with these urinary
Your body
symptoms.
mass index.
Body mass index.
Okay. Yeah.
Yeah. So again, maintaining a lower fat or increasing the amount of fruits and vegetables in the diet and exercise have been shown to help with some of these symptoms.
Our listeners can't see us, but I'm smiling because we've done, I don't know how many different shows about how many different medical topics, and a Mediterranean diet seems good for just about anything that ails you, whether we're talking about heart disease, kidney disease, lower urinary tract symptoms, high blood pressure. It's just remarkable how much diet plays into our health in a wide variety of ways. Let me circle back to the kind of medical aspects of this. You said that these symptoms are very common, become more common as we age. I'm a man in my late 60s. I can tell you that when I get together with my buddies, there's nobody who sleeps through the night without having to get up to urinate. At what point would you say, gee, this is something that you really ought to go see a urologist about or get a medical evaluation for?
First, I'll start off and say that we're always happy to see patients no matter how severe the symptoms are, right? We're always happy to come in, examine a patient, check you out, and make sure everything is looking okay. And a big part of this is, yes, there's these symptoms, but how much do they impact your quality of life? So that's a big thing we also look at is this impacting your quality of life? How much does this bother you? Because that affects potentially how aggressive we are in the treatment. In terms of, worrisome symptoms that patients should worry about, obviously if patients are experiencing, urinary tract infections, burning when they pee or pain, or if they're experiencing blood in their urine or worsening kidney function, that can sometimes be a sign of, maybe worse bladder functioning. We also sometimes see patients that cannot urinate at all, that feel full and have to have a catheter, and that's something that we sometimes see patients for.
Okay. If somebody does land in your office because they're concerned about this or it's gotten worse or for whatever reason, what's the typical evaluation that you undertake to sort out what's the underlying problem here before we get to what to do about it?
Typically starts with going through a lot of these symptoms that I talked about. So how long has this been going on? What are the particular symptoms? How often are you peeing at night? How often are you peeing during the day? Sometimes we have patients fill out questionnaires. There's some validated questionnaires that ask a lot of these same questions. and then have a quality of life component. And that can be helpful because when we see patients for follow-up, they can refill out that form and we can have an objective measure if they're getting better. So it involves a history. We also look at, fluid intake, those irritating fluids that I was talking about, how often people are drinking. We also look at medical history. So there are some other medical problems that can sometimes cause some of these urinary symptoms.
Say more about that.
A couple things. So one thing that we see patients for a lot is sleep apnea. So sleep apnea is a condition, we also call it OSA, obstructive sleep apnea, where patients' airways can be obstructed or blocked overnight from some of their soft tissue. And that can cause turbulent flow and can cause patients to be short of breath and wake up. So patients are, number one, waking up more because they're not getting enough air. But two, it actually puts pressure on the heart and it can actually make you produce a substance called ANP that tells your kidneys to make more urine. So patients can actually physiologically make more urine at night. There can also be heart problems, so we often ask patients about, do you have any leg swelling? If you think about just gravity, if you're sitting or standing during the day and then at night you lay flat, if there's some extra fluid on your legs just from gravity, that'll be reaccumulated into your bloodstream and you'll urinate it out later. There's also neurologic conditions, stroke, spinal cord injuries that can play a factor. Diabetes, often, one of the symptoms of diabetes is that glucose can get excreted into the urine, and even some of the newer medications for diabetes can cause that. So we take a look at some of these things. Some blood pressure medicines, diuretics, can cause you to make more urine. So those are things we look at. And then again, metabolic syndrome, like we talked about, can increase your risk of some of these.
So you're taking a comprehensive history to see if they have any of these other medical problems. They're taking any of these medications that may induce more urgency to urinate. What other kinds of tests are you doing?
So we also do a physical examination, in men that may involve a rectal exam or, feeling the prostate. In women, it may involve a pelvic examination. We will often do what's called a post-void residual. So it's a little ultrasound in the office where after a patient urinates, we do an ultrasound of their bladder to see how much urine is left over in their bladder. Bladder should be almost completely empty after you're done urinating, but some conditions can cause you to retain more urine. So that's something we look at. We will sometimes do what's called a uroflow study. So we'll have a patient urinate into a funnel to evaluate the force of their urination. And again, and this is typically a little bit more relevant in men. Men can have obstructive processes like an enlarged prostate that can cause a slow flow, and we can pick that up on that. We also do urine studies looking for protein, blood in the urine, sign of infection, do some blood work looking at kidney function in men, screening for prostate cancer. There's additional tests that we can do based off of that, things like more specialized ultrasounds to assess the kidneys, to assess the size of the prostate, bladder wall functioning, camera tests, and there's other tests that we may do based on if we find something abnormal on the initial workup.
So it sounds like all of this is designed to first answer the question whether this is something affecting the lower urinary tract that's not intrinsic to it, like a medication or some systemic illness. And then you're trying to categorize people into these obstructive and
irritative. Yes.
Okay. You've done your history, you've done these evaluations. So now what? What do you have to offer people to gain some relief from these symptoms?
The way I like to think about it with these conditions is, we think about it like a stepwise ladder. So with every rung or every step you go up, you may be doing stuff that's a little bit more aggressive or, have more side effects, but it maybe works a little bit better. So we start with lifestyle modifications, adjusting fluids, things that we talked about, work on the medicines, procedures, and surgeries. So, with lifestyle modifications, oftentimes we'll look at their fluid intake, talk about irritating fluids like I talked about. For men and women that are urinating a lot at night, we often tell them to stop drinking fluids within a couple hours of bedtime. If men or women have lower extremity edema, we'll often recommend, raise your feet for an hour before bed or wear compression stockings to get rid of some of that.
The idea is that you mobilize some of that fluid before they get into bed, and so that they're more likely to be able to urinate before they go to sleep and then less troubled at night.
Exactly.
Okay.
They'll urinate that fluid out before they go to sleep as opposed to in the middle of the night. And again, we counsel about weight loss, exercise. There's actually a study that, just walking for 2 hours a week can decrease your risk of developing some of these urinary symptoms. So
and what's the connection there?
there's a lot of different hypotheses about why that's the case. It may have to do with this, metabolic syndrome and inflammation, and also, if you're losing weight, is there less pressure on the bladder? So we don't really know. But I will always encourage patients also for their overall medical health that just walking 20 minutes a day can help with some of these symptoms.
Right. So that is in the same category as what we were talking about before about a, quote, heart-healthy diet is probably good for lots of things beyond your heart.
Exactly.
Okay.
Other things we talk about behavior. So, there are certain you're asking about risk factors. There are certain professions that actually can predispose people to having some of these symptoms. So, there are certain professions, nurses or teachers, where people can't go to the bathroom when they feel full. They're in front of a classroom, or they're with patients, or airline pilots or taxi drivers, and that can actually kind of weaken the bladder. So we encourage patients to, not pee when you don't have to, but if you have the sensation to urinate, you shouldn't really hold it for too long, and you should let yourself go to the bathroom.
Yeah, can I just follow up on that a second? Because there was something in the New York Times not long ago counseling, or at least cautioning against urinating too frequently when you don't really feel the urge. Could you speak to why that might be a problem?
This is something that we're taught as young kids, right? And I have a young daughter, and before we go out, we
Right.
encourage her
Used to go before you go.
Go to the bathroom. So
Right.
it's something we're taught from a young age. But the whole idea is that your bladder is a muscle, but it's not a muscle in the same way as your arm that you can just move it on demand. The normal process is that when your bladder feels full, it sends a signal to your brain that, it's time to pee, and you can go to the bathroom and release. So, the idea is that some of these taught behaviors of, doing what's called convenience voiding, of going to the bathroom, maybe not when you have to go, but just, because you're around a bathroom, because you're going to go for a car ride, can sometimes train your bladder to say, if you're going before your bladder has its normal capacity of about, what I said, a soda can, or about 500 milliliters, if you're training your bladder to think that, that this is my normal capacity. If I'm urinating before my bladder is actually full, your bladder may start to think that is its capacity, and may make you go to the bathroom more frequently. Yeah. And we sometimes will use that same idea and same strategy for patients that are having a lot of irritative symptoms. If they're saying, I'm having a lot of urgency or frequency, we'll sometimes counsel patients to do what's called bladder training, to either distract yourself when you have that urge. And
so it's kind of the opposite of that, tolerating that sense of urgency for a little bit longer so that you retrain your bladder to accommodate a larger volume.
Exactly. Now, I don't want people to hear this and think that it's a bad thing to do to go to the bathroom if they're on a long car trip. Doing it infrequently is okay. And, if someone has a lot of issues and they're going to be going for a long car ride, I think it does probably make sense to use the bathroom before they go, to avoid having to pull over their car. But the idea of using the bathroom on a regular basis can lead to some of these things we're talking about.
We were talking about this sort of general therapeutic approach. We were talking about lifestyle issues first. What comes after that?
So after that, there's some supplements that can sometimes be helpful. So, there's a supplement called saw palmetto that's thought to help with some of these symptoms in men. It can help, relieve some of the obstruction, similar to some of how the medications work. There's other, cranberry has been shown to decrease the risk of urinary tract infections and can sometimes be healthy for bladders. But after supplements, we move on to prescription medicines. Prescription medications are targeted towards various things. So in men, there's medicines that are designed for the prostate. There's medicines that are designed for the bladder. And in women, it's some of the same medicines that we use for the bladder in men for the women, but they're designed to help with overactivity or slowing down the bladder.
So those are kind of targeted muscle relaxants for the bladder.
Correct, yes.
Okay.
And there's two main classes of medicines in that category. There's something called anticholinergics. The bladder, again, is a muscle, and there's receptors that, get stimulated when it's time to void, and these block that receptor. They can have some side effects, dry mouth, dry eyes. There's some risk long-term use of, there's been one study that looked at dementia in long-term anticholinergic use. So something we have to counsel, especially our elderly patients, about.
And give us an example of a drug that falls into that class.
So ditropan, vesicare, tolterodine, sulfenicin, these are trospium. These are some of those medicines that fall into that class.
Okay, so you have anticholinergic, and then you said there was some other class.
For the bladder muscle, there's also something called beta-3 agonists. These are newer medicines. They work similar, that instead of blocking a receptor, they stimulate a receptor that induces relaxation. So those medicines are called mirabegron or virbegron are the two medicines. They don't have those same side effects of dry mouth, dry eyes, constipation. The main side effect of that is it can very mildly raise your blood pressure or cause a headache. So it's something we have to monitor in patients. So those medicines I prefer to use, especially in older patients, to avoid some of those other side effects.
And then if you're not targeting the bladder, but you're worried about obstruction in men, there's a whole different set of medications, right?
Correct. There's a class of medicines called alpha blockers. These are medicines like Flomax or Uroxetrol. They usually end in ocin, the generic name, so tamsulosin, alphazocin. How they work is they relax the smooth muscle in the prostate and at the bladder neck to allow for more relaxed voiding. So, when your bladder squeezes, if you have an enlarged prostate, the bladder has to work hard to go against that blocked prostate. So men that have an enlarged prostate can have both those obstructive symptoms and those irritative symptoms. And the obstructive symptoms, again, it's just mechanical. It makes sense. If your bladder's squeezing and it's blocked, you're going to have a slow flow. You're going to have to push. You're going to have to wait a while. But the irritative symptoms can happen because if your bladder's working hard for a long time against a blockage, it starts to get a little, overactive and start feeling like you have to squeeze more. So the idea is that if you can relax the prostate, you may A, help those obstructive symptoms, B, help those irritative symptoms. There's other medicines for the prostate. There's a medicine called finasteride that can block the conversion of that testosterone to dihydrotestosterone and actually shrink the prostate. Has main side effects of that are there's some sexual side effects, so about 5 to 8% of men can experience either lowering of their sex drive or erectile dysfunction. So it's always something we have to be upfront about. If sexual side effects are a big concern, actually some of the erection medicines that we use, specifically Cialis or Tadalafil, that's FDA approved both for urinary for enlarged prostate and for erectile dysfunction. So taking a low dose once a day Tadalafil can actually help in a similar mechanism to the Flomax, the relaxing medicine, to help relax the urinary flow.
And I guess there are surgical approaches as well, right?
Yes, there's surgical approaches. There's some office-based approaches we can do, things in the office to relieve obstruction of an enlarged prostate. And then there's also surgeries we can do for an enlarged prostate. Now, I'll talk about men and I'll talk about women after. So, for men, we like to think of who needs a surgery or who needs a procedure for their enlarged prostate. So the people who need a procedure are people who cannot pee and have to have a catheter, people who it's backing up to their kidneys and they're experiencing some kidney dysfunction. People are getting urinary tract infections, maybe getting bladder or kidney stones as a result of this, recurrent blood in the urine. So those people need to do something. The people who have the option to do something are people who don't tolerate the meds. Maybe they're experiencing side effects and they don't like the medicines, or they're on medicines and they're still experiencing inadequate symptom relief. So, those are men that we can consider doing these procedures on. And then again, based on how large a man's prostate is, the shape of the prostate, risk tolerance, will guide whether or not we do some of these office-based therapies or these operating room procedures. For women, we have some procedures we can do as well. So one procedure we can do in women is Botox into the bladder. So if women are having irritative symptoms where their bladder is squeezing too frequently, we can inject Botox into the bladder. And this is an office-based procedure. And the idea is you hear Botox that you inject into your forehead. It stops with wrinkles. And the idea is it paralyzes the muscle of your forehead to prevent wrinkles. So it does the same thing in the bladder. It stops or slows bladder contraction so women don't have this problem anymore. One other procedure that can be done in women for some of these symptoms is actually like a pacemaker that can get implanted into the lower buttocks, and then the leads go into the spinal cord. And the mechanism is not exactly understood about why this helps slow down the bladder, but it has been shown that putting this pacemaker in and giving periodic pulses to some of the spinal cord nerves that affect urination can slow down urination.
All in, when you're talking about these medications and maybe surgical procedures, what percentage of people are you able to get to a point where they say, oh, this is no longer limiting my lifestyle, or it's an acceptable level of functioning?
It's different for every patient, but I do think we get most patients to a point where they're either happy monitoring their symptoms, either with the lifestyle modifications, with medicines, or that progress to surgery. Now, again, it's also about risk tolerance and age of patients. Some older patients maybe don't want to undergo a surgery or worried about their other medical issues. But I think most patients we can get to a point where they're at a steady state and they're comfortable with their symptoms. And that gets also into the whole quality of life aspect, because some people come to me because they're very bothered by their symptoms. Some people come to me at the insistence of a family member or by the primary care doctor, or they just want to be checked out and make sure everything's okay. So if someone has some of these urinary symptoms, but they're really not that bothered by their symptoms, they're emptying their bladder okay, kidney function's okay, everything else looks all right, we really don't have to do anything.
Yeah. I think this has been great. Thank you for sharing all this information. If people want to get more information, where would you direct them to get high quality, sort of medically valid information about what we've been talking about?
The AUA, which is the American Urology Association, it's kind of the main association for that physicians use, but they also have patient education and kind of some very user-friendly stuff on their website, and also some information for patients to access to talk about these various issues.
Okay, great. Well, thank you very much.
Thank you so much.
My guest has been Dr. Adam Cole. He's a board-certified urologist and the Associate Residency Program Director for Urology at the Zucker School of Medicine program at North Shore LIJ. Thanks also to our editor, Edward Lee, our producer, Connor Pilkington, and our audio engineer, John Mullen. For more information about this particular program and to find all of our past episodes, please visit our website at medicine.hofstra.edu/wellsaid. You can also subscribe to our free podcast wherever you get your podcasts. Our listeners are also welcome to send their comments, suggestions, and questions to wellsaid@hofstra.edu. Until next time, I'm Dr. Ira Nash, and that's Well Said.